All right, good morning. Hi, my name is Wilson Gonsalves, and I'm from the Mayo Clinic in Rochester. I work in the myeloma, amyloid, and dysproteinemia group there. And so to end this session, I'm going to touch bases on updates in myeloma from ASCO 2019. I'm going to keep my phone right here, so I didn't think about time limits. So, all right, so we'll see how this goes. All right, so I have no disclosures for this talk. And I put some CME questions, but I'm wondering whether we should do these at the end or do them right now?
We can do them now and at the end.
At the end, okay, all right. So I put two questions here. The first question is, which of the following is consistent with high-risk smoldering multiple myeloma? And you have four choices, and they're essentially just bone marrow plasma cell percentages, M-spike levels, and serum free light chain ratios. And feel free, it looks like this is a way to respond electronically.
Right, so essentially you text SCHAT18 to 22333, and then you select whatever options you think is appropriate.
All right, so looks like there's a unanimous 100% choice for C. I may have to change my talk for this. All right, this is a little longer question, and it's a little bit of a cop-out, but it kind of summarizes everything I'm going to talk about. So which of the following statements is incorrect? Which, by the way, you cannot put on your board exams anymore. You cannot do what's not true. So A, triplet induction therapy with bortezomib, lenalidomide, dexamethasone improves progression-free survival and overall survival compared to traditional doublets like lenalidomide or dexamethasone. Or B, quadruplet induction therapy. So this is with daratumumab in combination with bortezomib, thalidomide, and dexamethasone, improves PFS and OS compared to bortezomib, thalidomide, dexamethasone. Or C, is autostem cell transplant. It appears to better sustain your MRD negativity at 1 year compared to conventional induction therapy. Or D, subcutaneous daratumumab appears to be safe and non-inferior to IV daratumumab. So which one of this is not true? Okay. Okay. Oof. All right. Okay, with that, it keeps changing. Is there a time limit of how long I wait? All right. Few seconds, okay. We'll see how this changes. Okay, great. All right, so we'll come back to these questions at the end. Okay. There you go. All right. So, traditionally ASCO is not really the big meeting for myeloma updates. It's usually ASH, but I would say this was a very busy ASCO. And so we had several different abstracts that were of interest in clinical practice. And I'm going to basically divvy these up into three sections. I'm going to basically talk about smoldering myeloma, newly diagnosed myeloma, treatment of relapse and refractory myeloma, and just ended a little bit with some of the novel new kids on the block type agents that we hope to see in the future. So a little bit about smoldering myeloma. So this abstract was presented by Mari V. Mateos as part of the IMWG update on risk stratification in smoldering myeloma, and a little bit of background on this. So we all know that smoldering myeloma is kind of this heterogeneous group of patients, right? So our gold standard is, MGUS. All myeloma starts from a precursor clonal plasma cell disorder called MGUS, and the risk of progression of MGUS to multiple myeloma has really been averaged about 1% per year. Now, smoldering myeloma, on the other hand, is this other group of patients where they have higher disease burden but don't have any end organ damage, so no hypercalcemia, renal dysfunction, anemia, bone lesions, and so forth. But as you can see, their risk of progression is very different. So you can see in this group 1, they have the highest risk of progression. It's about 10% per year. And then this group right over here, roughly after the first 5 years, that risk drops down to about 5% per year to 3% per year. But then this very end tail group of the spectrum, their risk of progression to myeloma is really 1% per year. And so how do you actually tease this apart to figure out who is going to do what in terms of disease progression? And let me just go back. And so, one second. So what happened in 2014 was that there was a redefinition of the myeloma diagnostic criteria by the IMWG. So essentially, myeloma was you needed to have clonal plasma cells in your bone marrow, 10% or higher, but you also needed CRAB features, so hypercalcemia, renal insufficiency, anemia, and bone disease. But going back to this group of smoldering myeloma, you see there's a small subset of smolderers up here that in the first 2 years, they almost have like an 80% risk of progression to multiple myeloma. And what ended up coming from that, this was over 10 years worth of work, we came up with myeloma-defining events, which are added to the CRAB criteria for diagnosing myeloma. So if you have bone marrow plasma cells of 60% or greater, you have more than one focal MRI lesion in your bone marrow, or you have a free light chain ratio more than 100, all of those put you at a risk of 80% or more of progressing to multiple myeloma in 2 years. So rather than waiting to develop end organ damage, maybe you should start treating these patients right here. And really, so from 2014 onwards, this got incorporated as the diagnostic criteria for myeloma. So this abstract really says, okay, now you've taken this piece of the pie out for these smoldering myeloma guys. How do you risk stratify the leftover, or what you could call the new smoldering myeloma criteria, or the new group of patients on there? So work from a group by Dr. Shaji Kumar and Arjun Lakshman basically looked at providing a risk stratification score for these patients with smoldering myeloma who do not have any myeloma-defining events, because they'd be classified as myeloma now. And essentially, they came up with just this rule. If there's one thing you remember the 20-20 rule. So if you have more than 20% clonal plasma cells in your bone marrow, that's a risk factor. If you have an M spike greater than 2 grams per deciliter, that's a risk factor. And if you have a serum free light chain ratio greater than 20, that's a risk factor too. And so if you have 2 or more of those risk factors, you're in the highest risk. If you have 1, you're in the intermediate risk, and you don't have any of those risk factors, you're in the low risk. And you can see with this new cohort of smoldering myeloma patients with no myeloma-defining events, they split out really nicely. And this was important to do because if you look at a prior criteria that we used, the 2008 Mayo Clinic criteria, which I think maybe a lot of you all remembered and picked your answer based on that, was basically your bone marrow plasma cell percentage just had to be 10% or higher, and your serum-free light chain ratio had to be greater than 8. And you can see that model doesn't seem to be as robust, at least visually, compared to the new 20-20 model. So with that being said, the IMWG group basically went on and pooled patients from various countries, basically close to 1,200 patients, and applied that same risk stratification score. And bottom line is, you can see in the high-risk group, you can see there's almost a 50% risk of progressing to symptomatic myeloma within 2 years if you have 2 or more of these risk factors in there. So just something to keep in mind. So that is a segue for this clinical trial, which is probably one of the more important clinical trials presented at ASCO. This was the ECOG study that looked at treating smoldering multiple myeloma. And it was a randomized phase 3 trial that compared single-agent lenalidomide dosed at 25 milligrams on days 1 through 21 versus just observation. And this is the key part over here. The primary endpoint was progression-free survival, but progression wasn't just biochemical progression. We know that, yes, people's M spikes can go up, their light chains will go up, and so forth. It was biochemical progression plus any end organ damage symptoms like CRAB features on there. So that's really important. There was a phase 2 attached to it. This was a small study of just about 40 patients, and they just wanted to make sure this treatment was safe and people could mobilize and collect their stem cells and so forth. But essentially what they found was there was a huge difference in progression-free survival, hazard ratio of 0.28. Their 3-year PFS in the lenalidomide arm was about 91% in comparison to 66% in the observation arm. So based on that second interim analysis, when they found these differences, the study had to be unblinded and, not unblinded, but the data had to be revealed and so forth. So based on these results, they just went back and then looked at kind of a forest plot to see how did this do? And you can see almost everyone benefited from the lenalidomide. There's a small subgroup of African Americans, and it could be just because either they're small numbers or is there something inherently different in their biology is also a question. But more importantly, if you look at this 20-20 rule, those patients with the highest risk in that group seem to benefit the most. And so just something to consider. If you were to see a smoldering multiple myeloma patient now, and if you were to apply that rule, I would say the opinions are mixed, but there are more people in favor saying that if you have higher risk patients, you can at least consider treating them with lenalidomide or lenalidomide dex based on some Spanish data back in 2013 for this group of patients on there. Whereas those in the intermediate and low risk, ideally, if you could put them on a clinical trial or continue observation, is reasonable. Two things to remember, there are two ongoing clinical trials in the United States, and they're taking two very different approaches as the next step for smoldering myeloma. And basically what they're doing is that, so Shaji Kumar is leading the ASCENT trial. It's going to be a trial with curative intent. So can you give fixed duration of daratumumab, carfilzomib, lenalidomide, dexamethasone in these asymptomatic patients for 2 years and potentially cure them? It's a provocative question, but it'll be interesting to see what happens. In Europe, they're doing a similar trial, but they're taking it even further. You're actually going through a stem cell transplant and getting consolidation and getting maintenance and so forth. There's also an ECOG study, which is a follow-up to the study I just presented. And essentially, they're basically saying, okay, lenalidomide is good. Can we intensify that? And it's going to be a randomization of len-dex versus len-dex and daratumumab in these smoldering myeloma patients. All right, so with that, I will switch gears now to newly diagnosed multiple myeloma. And the CME questions killed my time, but it's okay. So just some basics. Risk stratification. You can put all myeloma in literally like 2 buckets, high risk and standard risk. These are some of the high risk cytogenetic abnormalities you all may have seen. And essentially, they kind of dictate a little bit of how we kind of proceed with therapy and maintenance and so forth. Oh, yep, sorry, 1 second. Yep. So the emerging treatment landscape in myeloma. So this is just a segue to tell you that in the last year, other than ASCO 2019, this Kaplan-Meier curve here for PFS is basically the Alcyone trial from Europe that compared daratumumab, bortezomib, melphalan, and prednisone versus bortezomib, melphalan, prednisone, so dara-VMP versus VMP. It's a regimen oftenly used in Spain and other parts of Europe. This is FDA approved in the United States for newly diagnosed transplant-ineligible patients. Problem is, I've never given it. I don't think most people ever give it because most people don't use oral melphalan up front anymore over here. However, the other study that also came out was presented at ASH 2018 was the Maya trial. So daratumumab, len-dex versus lenalidomide, dexamethasone in patients who are transplant ineligible in the upfront setting, showing a very significant progression-free survival benefit. And this just got approved this week by the FDA. So that lends to this study. So this was the large phase 3 study presented by Philippe Moreau as part of a combination from the French group, the IFM, and the Dutch group, which was the HO1 group. And so it's this Cassiopeia study that basically compared, for the first time, in newly diagnosed patients that are transplant eligible, can you give them daratumumab with bortezomib, thalidomide, dex versus bortezomib, thalidomide, dexamethasone? Not perfect for our practice because, again, none of us tend to use thalidomide up front either in these combinations. So this was really the study design, and they really presented just part 1 of the study. So everyone got randomized to either dara-VTD or VTD, then they got their transplant, and they got consolidation with either of those groups. And then they got randomized again to either dara maintenance or observation. And basically what they wanted to show was what were the outcomes in terms of responses at the end of this consolidation of dara-VTD versus VTD, all right? And basically you can see the response rates about the same, 90+%. But really the depth of response is what was better in here. And that was your primary endpoint. What was your post-consolidation stringent complete remission? And that was significantly higher in the patients who got dara-VTD compared to VTD. And then when you looked at MRD rates at the end of that consolidation segment, that was also significantly higher. And that was true across the high-risk cytogenetics and also with the higher ISS disease states. And just with 18 months of follow-up, so about 1.5 years, you could see that there was already a noticeable progression-free survival in this that was statistically significant of 93 versus 85% at 18 months. No overall survival benefit yet, but this is, of course, an early readout. So time will tell where this will fall. As far as safety issues, really, other than some added hematological toxicities and infusion reactions, pretty well tolerated. The key thing over here, which I don't have on the slide, is these all transplant-eligible patients, did they have any issues with mobilizing their stem cells? And the answer is no, they all engrafted. But if you look at the numbers, you can actually see that the number of stem cells collected were a little lower. More people needed plerixafor and so forth. But that being said, they were all able to make it through transplant. So that makes me go to this next study, which is an older study, but they presented a new analysis on this. This really looked at, this is an Italian study looking at carfilzomib, lenalidomide, dexamethasone in the upfront setting in patients who are transplant eligible. And this was basically saying you get KRD induction, but then you either continue on KRD versus you go get a stem cell transplant and consolidation before you get randomized again. And so they're really comparing the blue arm here versus the green arm. So everyone got KRD, but then half the group went on to get a single stem cell transplant followed by consolidation versus you just stayed on KRD before you got randomized to lenalidomide versus carfilzomib and lenalidomide. So bottom line, what they wanted to show is that overall response rates really look about the same. The MRD rates, the MRD negativity rates by next generation flow, roughly about the same. The overall response rates, roughly about the same. VGPR or better rates, roughly about the same. But really, what they wanted to then do was they were actually serially doing bone marrows and monitoring the persistence of the MRD. And what you can see here is if you take those two groups, the guys who got induction and then transplant versus just staying on KRD, only about 3/4 of both groups had that data, but the persistence of MRD negativity appears to be higher in the group that went through a stem cell transplant compared to those who just stayed on KRD. And then if you specifically look at those patients with higher risk, which they kind of grouped as RISS stage 2 or 3, they seem to be higher again in the folks who went to transplant as consolidation versus just staying on KRD for 12 months. When you looked at early relapse, and what they defined as early relapse is from your diagnosis, if you relapse within 18 months, which is what we now in the myeloma world are calling functional high risk, irrespective of what your genetics are. If you relapse after your first line of therapy at 12 months in your standard risk, you're kind of functional high risk. There's something about you that's different. And over here too, they show that the early relapse rate over there in patients who go and get a stem cell transfer for consolidation appears to be lower than if you just stay on KRD for 12 cycles. And so just in a nutshell, this is kind of how we kind of just manage patients in a risk-adapted fashion. So if you're in the standard risk portion, you all of us give VRD induction. We prefer to take everyone who's eligible to a stem cell transplant up front. We all give len maintenance for them if they're standard risk for a minimum of 2 years. If they want to go to a delayed transplant, we at least collect their stem cells and then keep them on lenalidomide and dexamethasone until progression. This high-risk bucket over here, this is a little controversial. I would say VRD is the approved standard. We've been playing around and giving KRD up front, so people always ask us, where's the data? And part of it is just because this population still does poorly. And so at least based on phase 2 data, the depth of response appears to be better with carfilzomib, so we've kind of taken the leap of faith. It doesn't mean it's the right thing. I guess we'll see what happens as trials come out. And we try to get everyone to a stem cell transplant if they're eligible, and we tend to use more of a proteasome inhibitor-based maintenance approach rather than lenalidomide in patients with high-risk disease on there. Whereas if you're transplant ineligible, which is roughly about half our patients on there, we still give VRD. Depending on the frailty, we'll do VRD light and lower the doses a bit, and then we'll keep them on maintenance for at least a year. If they have high risk, we again give VRD, adjust the doses for their age and their frailty, and we still pick a bortezomib-based maintenance regimen in there. All right, so now I'll switch gears, and I will touch bases on relapse refractory myeloma. So this is pretty quick. You have a buffet of treatments you can use for relapse disease after first relapse. So and a lot of our decisions are really made on, hey, are you relapsing on lenalidomide maintenance? Are you relapsing on bortezomib maintenance? And we kind of switch and play around with the drugs. There are no head-to-head trials with any of these, so I can't tell you what's better and what's worse and so forth. But you have drugs from daratumumab, from carfilzomib-based combinations. You have elotuzumab-based combinations, ixazomib-based combinations, and so forth on there. But in this space, Paul Richardson presented phase 3 data comparing an other anti-CD38 monoclonal antibody, isatuximab, in combination with pomalidomide and dexamethasone, and that was compared to pomalidomide and dexamethasone. And basically, this is another IgG monoclonal antibody that targets CD38 on there. Phase 1 data showed that it was efficacious in that combination, and so they took this group of patients who had seen at least 2 or more prior lines of therapy. They've all seen lenalidomide and a proteasome inhibitor, and they were randomized to either arm in a 1-to-1 fashion, and they looked at PFS in this group, and you can see there was a significant improvement in progression-free survival by about 5.5 to 6 months almost in there. As far as overall response rates, you can see there was an improvement in overall response rates and also a slight improvement in the depth of response. These numbers look a little deceiving, and they claim that part of the problem was getting people into a CR is a little tricky when your monoclonal antibody gets detected by immunofixation, so they end up being labeled as VGPRs. But it does look like it does improve the depth of response there too. As far as toxicities, so the biggest thing to look at, they're roughly about the same, but in isatuximab, and most people who have been giving daratumumab now for a while have probably noticed you're just seeing a lot of lung infections and pulmonary toxicities. And you can see in this group, upper respiratory infections, bronchitis, pneumonia is definitely higher than just pomalidomide and dexamethasone. So something to kind of keep in mind on there. And then the last thing in this space is really looking at subcutaneous daratumumab versus intravenous daratumumab. This was already presented as a phase 1. To the phase 1 portion of this was presented, I want to say 2 or 3 years ago in the PAVO trial. And basically, this was a phase 3 non-inferiority study in randomized patients to sub-Q versus IV. The thing about sub-Q is 1,800 flat fixed dose, so no dosing based on weight like the 16 milligrams per kilogram. And essentially, the things they wanted to look at was, are response rates the same, and a little bit about the pharmacokinetics. Is their maximum concentration at the trough level the same too? And this is a no-brainer. The time taken to give you sub-Q, 5 minutes, versus you've all gone through the daratumumab infusions, and they take forever. You can probably do rapid dosing, rapid infusion, 90 minutes now. That's what most of us are doing. But the overall response rates appeared to be about the same. There wasn't any difference. It wasn't inferior. The sub-Q wasn't inferior to IV. And looking at the PK studies, the maximum concentration trough dose at cycle 3, day 1 was also roughly about the same. And so basically, this trial met criteria for its non-inferiority. Secondary outcomes, PFS, OS in this group, also virtually identical on there. And just things to consider, it doesn't mean you can't get infusion reaction, even with the sub-Q. You did have some symptoms. I don't know why they call it infusions, but it was roughly about a third less than what you saw in the IV daratumumab arm on there. As far as typical toxicities you see with daratumumab, it was roughly the same across the board in both groups. And so, with that being said, I think sub-Q dara is probably going to be here soon, and it's probably going to be a huge help on infusion centers and so forth. So here's my last part of the talk, and let's see how much time I have. Great, I have 2 minutes. So, all right. So I'm just going to touch bases on 2 novel therapies, and then we'll be done. So first, everyone's heard about immunomodulators, thalidomide, lenalidomide, pomalidomide. This is, if you want to call it, your 4th generation or 3rd generation immunomodulator, CELMoD, iberdomide, CC2220. And basically, Sargalonia from memory presented this data. And in a nutshell, this is a more potent IMiD. It degrades the downstream proteins from cereblon, like Ikaros and Aiolos, in a much more potent fashion if you look at the EC50s compared to Len and Pom. And this phase 1/2 study has been going on now for the last couple of years, and really what they presented was just the data on its combination with dexamethasone. This is an oral pill that's given same way like all the other IMiDs, days 1 through 21, followed by a week off in combination with weekly dexamethasone. And you can see that in this group, this was a heavily pretreated group, but more important, more than 2/3 of the group were refractory to proteasome inhibitors or IMiDs, and at least close to 3/4 were refractory to daratumumab-based therapies on there. The side effect profile, if you look across all cycles for this drug, appear very similar to most IMiDs with hematological toxicities, but surprisingly not a whole lot of neuropathy, not a whole lot of diarrhea, which you sometimes see with lenalidomide, so appeared to be roughly about what we expect with other IMiDs. The overall response rate in this heavily pretreated group is roughly in the order about 1/3 of the patients, depending on whether you're IMiD refractory or dara-pom refractory. You roughly had, you can say, a flat 1/3 of the patients responded, which is very equivalent to what the data looked like when lenalidomide and so on were coming out. This slide, I just want to put this on just to tell you that these, as the dose levels go up, you can see that there are responses, and the responses take place over time. So people will start off with MRs and start to get PRs. But as you're going higher in the dose, and right now they're in this range, you're starting to see deeper responses of VGPRs and so forth. And the last drug. So you can't talk about myeloma without talking about some sort of anti-BCMA based therapy, whether it's CAR T or BiTE therapy or antibody drug conjugate therapy. And so the study that was presented here was the Amgen BiTE molecule, so the bispecific T-cell engager molecule, AMG 420. And basically, a very interesting drug, great efficacy. It sounded horrendous when you're looking at this. It's basically a continuous IV infusion for 4 weeks. You basically walk around with a pump. Each cycle is 6 weeks. And essentially, they started at a very low dose of like 0.2 micrograms per day, and they have gone up all the way to 800 micrograms per day. Most of the reasons why people came off the study were due to progressive disease, very few true adverse events related to the drug itself. But what you can see here is that in the lower doses, you didn't see a lot of responses, but once you start hitting the 400 micrograms per day dose, you can see a lot of CRs, you can see a lot of MRD negatives starting to take place. The 800 micrograms per day just got discontinued, I want to say a few weeks ago, due to DLTs and so forth. So this is going to be your MTD dosing that's going to hit the phase 2 side. So something to look forward to, given that treating this very relapsed refractory population is quite challenging on there. So just to summarize, this 400 micrograms per day infusion, you had basically a response rate of about 70%. You had about half of them have MRD negative type disease responses. Very encouraging. Are they going to be durable? Only time will tell here. And last 2 slides on just in the same space of anti-BCMA. So they are antibody drug conjugates. So just like it was begged and borrowed from the lymphoma world, GSK had this compound that had a very long number and was just known as the GSK drug, but now they have an even more complicated name of belantamab mafodotin. So if you can pronounce that, that's great. But once again, overall response rate, 60%, heavily pretreated. This was just the phase 1. There are ongoing studies in phase 2 and in combination with IMiDs and carfilzomib. So this is definitely something that is promising in patients who are very heavily pretreated in there. And then last slide, I keep saying last slide, but this is my second last slide. So I have 3 CAR T. That's probably the most exciting in myeloma, but I would say you have 3 different front runners. I think BB2121 by Bluebird / Celgene is probably in the lead. Their phase 2 is open right now. Very good response rates, mid-80s to 90s type response rates. I would say one thing, if most people probably saw the NEJM paper out, it's a little sobering when you see that the median PFS is still a little less than 12 months. So there's probably more work to fine-tune these CAR T treatments on there. So in summary, so high-risk smoldering myeloma can be considered for early therapy, either Revlimid or Rev-Dex after thorough discussion with the patient. Clinical trial is still preferred to determine optimal regimen. Quadruplets, they're probably here. I mean, all the trial designs, they're ongoing trials comparing DARA VRD versus VRD, and that will probably dictate how we practice in the future. I don't have a crystal ball, but I'd like to think that that's where the field is going. I think stem cell transplant still remains an important component of therapy. People always want to ask controversial questions of, is stem cell transplant dead? And I don't think it is yet. Maybe it will be, but I think it's really early to say that. I think it's still important to keep that in mind. Isatuximab is likely going to be this new CD38 antibody that's going to hopefully be FDA approved. How do you choose between daratumumab and isatuximab? I'm not entirely sure. We'll just have to see how it plays out. Subcutaneous daratumumab will probably be something that will come into practice pretty soon and will hopefully help all of us. And of course, novel agents in the mix, the next generation cell mods like iberdomide, and of course, anti-BCMA immunotherapy, whether it's BiTE therapy, whether it's antibody drug conjugates, whether it's CAR T, hopefully, they definitely look like they're on the right track to being prime time in clinical practice on that. And with that, I will end. And okay, so you get questions again. All right, so you get a retake on your exam here. So, how am I doing for time? Okay. So it's great. We converted everyone from C to A, and then, yeah. This is kind of actually, this is one of those questions I hate because you don't. Oh, people still believe it's C. Must have spoken really fast. Okay. So all right. So just a quick thing. It was going to be B, and A looks very enticing. But the only reason I say it's not A is because these people probably have myeloma right now. Because with the myeloma defining events, 60% or higher. Vince Rajkumar presented this data all the way back in 2010. Like if you have that, your actually risk of progression in 1 year is almost like 90%. I would say out of all those 3 new criteria added, the bone marrow plasma cell percentage, if you have 60% or higher, that's, that is probably the biggest thing to consider as myeloma. So yeah, it would be B. So they have more than 20%, their M spikes more than 2, and their serum-free light chain ratio is more than 20. And it's such a, there are people who still don't believe me, and they're just not changing their answer. It looks like, okay. All right, and last one is, perfect, yep. All right, yep, so, once again, it was midnight when I was trying to write these questions, so this was the easiest cop-out to just summarize everything in here. But essentially, we don't have overall survival with these quadruplets yet. We won't have it. This is the field of myeloma. You have 16 different FDA-approved drugs, one way or the other, that you can sequence. It's really difficult to get overall survival data with a median follow-up of 18 months from there. So, and with that, I think I'm done.